Hello, everyone. My name is Noel Paradero, and I will be presenting the principles of developing TB model of care, which is decentralization. And I would like to begin this presentation by acknowledging the traditional owners of the land on which I do my online presentation today, the people of the nation, and pay my respect to elders past and present. For the introduction, this presentation will talk about the centralization TB model of care adopted by Regional New South Wales Murrumbidgee Local Health District. The objectives of this presentation is to, first, identify and describe the goals and principles that underpin the model of care development. Second is to analyze the clinical public health and nursing care needs arising in the delivery of model of care, tuberculosis prevention, treatment and care, and lastly is to discuss the roles and responsibilities of key stakeholders in the model of care that contributes to achieving patient-centered health outcomes. Focusing on task one, which is the goals and principles underpinning the development of model of care. The development of strategic planning, social reforms in health, and development of ongoing quest for model of care is made through the creation of Alma-Ata Convention held in 1978. So this is what happened in 1978. The World Health Organization ratifies the principles of health is for all, and they considered health as a fundamental human rights. And the aim is to ensuring that the people have access to care. In 2008, New South Wales Civil Services adopted the model of care called decentralization. In 2014, WHO ratified End TB strategy, which is aiming to eliminate TB by 2050. This developmental strategy is not one size fits all approach. In developing nations where TB incidents are high, this strategy serves as a blueprint to reduce TB incidents by 80% and TB deaths by 90%. And in Australia, we also have a fair share to this goal. Majority of our cases are coming from high TB burden countries, and we have a well-structured existing model. As per Communicable Disease Network Australia, we have a well-structured TB programs through Australian Immigration Health Assessments, Occupational Health TB screening, BCG immunization, which is the health promotions, and a chest clinic services. Existing model of care are often challenged as not responsive to the changing needs of contemporary health system, and this is the principle of ongoing research and development of model of care. So what's really decentralization look like? As you see here, this is the earliest times recorded in the history that shows the benefits of decentralization was dated back in 1917. And over the years, there are issues over this concept and are quite challenging. Most of the countries adopted this model of care, like in the Philippines, where I studied nursing and worked with TB patients. Then I moved to UK in 2009. I also learned about this model of care while caring for refugees and asylum seekers. And can you see here, World Health Organization recommended the centralization model of care for multi-drug resistant TB patients. Again, this model of care is being used by so many countries, like Philippines, Brazil, Indonesia, just to name a few. And if you're going to read all of those documents, and also NSW health documents, you can see the goal is to have an access to healthcare service. But the problem remains the same, the fundings and staffing. If there's no funding and staffing equals no access. I acknowledge that Australia is a low TB incident country, and the situation is different from other countries. With issues of funding and staffing problem, a country that tuberculosis is not considered a risk, it is hard to articulate propositions supported by good research. But we have inclusive communities in Asia and Pacific region around us. We have the ability to influence others as we demonstrate leadership and working with regional partners. There is a term called devolution, which means local government unit or LGU. There is a transfer of power delegation in independent decision-making process. Devolution means power and authority of management, planning, and decision are disseminated in lower management level. So if you're going to talk about decentralization, you need to talk about devolution. In healthcare perspective, it simply means the creation of local health district. But before we go anywhere else, let's first define what is a model of care really. And I took this definition from NSW, Agency of Clinical Innovation, and I quote, model of care, it is defined as an evidence-based practice and service delivery for an individual, family, community, or a particular sample or population. It is a quality of care developed aiming for a better quality outcome. It is initiated by clinicians ensuring people get the right care at the right time by the right team in the right place. Again, as I have said, in 2008, TB decentralization model of care was adopted in New South Wales. And in the 1st of July 2011, as part of national health reforms, NSW is the first state in Australia implemented locally managed health districts. Moving on to task 2, which is the theoretical concept of decentralization TB model of care in tuberculosis prevention, treatment, and care. We're going to define the decentralization, the clinical aspects that we have here in Wagga Wagga, the nursing care we provide, the public health, and the outcome. So for the definition, decentralization model of care strategy is to improve health system performance by bringing decision-making closer to service delivery. It ensures that patients have access to care, not just an access to care, but a quality service with good treatment and being able to be treated and safely using person-centered care, which is enabling and recognizes the principles of self-determination. We use this translator. We put the patients at the center of the care, making them an active participants of their care. We have a wide range of services. We go to people's places who are required TB screening, investigations, and treatments in our region. And for the clinical aspects, deliver in variety of settings, connecting along the way that provides synchronicity of diagnostics, decision-making, and treatment. So through decentralization, clinical management delivers in that variety. They are available 24 hours, 7 days a week. Processes will be interactive, connecting along the way beyond places. There is a case manager. We have TB nurses, community nurses doing BDOTs and referral 24/7. And for the nursing care, we provide patients will be invited to take part in their decision-making, guiding by health education to better understand and create a care plan that matches their need and expectations and values. Patient-centered, patient engagement. Patient will have a different care needs, and care plan will be designed according to their needs and circumstances. And for the public health aspect, working together between disciplines and specialists, always sensitive to time, access to healthcare, and around the clock. There will be a development of management plan in a coordinated way and collaboration with other public health units. Local government districts have their own specific fundings allocation. Accessibility of care is free and requiring no Medicare membership. So it means TB health service is free for all. And for the outcome, TB service will provide healing experiences with the patient's caregiver's family in a meaningful way. So we will transform what we do to deliver the best possible experience and care for patients, which are based on mutual trust provided by our team. So if we have a patient needing services like an active patients, we provide access to care. Doctors available around the clock, community nurses are empowered to do sputum collections, symptoms checks and VDOTs. We have a public health support. We are together with pharmacies, radiologies, and pathologies. Moving on to task 3, what are the roles and responsibility of stakeholders in this model of care? TV Community Health Service or the CHESS Clinic engaged with the client in a more meaningful way and involved private sectors in order to reach to more people. So the key word here is engagement. So to engage a client, it should start first through knowledge empowerment, through health education. Through the through decentralization of service, which makes the health services closer to them, they will be provided avenues to engage to their clinical and nursing care planning tailored to their unique risk factors and situations. For example, if someone wants to work in a hospital and this patient is an LTBI patient with no symptoms, healthy and well, chest x-ray is clear, IGRA is positive, there is no need for any delays for someone to work or start working. For a staff health perspective, there are no concerns about active TB disease, nor does a positive IGRA preclude someone from working or hinders visa application. Without decentralization, patients will struggle to access and the barriers they have to travel, place his resources or money and put an effort to seek TB service, especially in regional area like Wagga Wagga. Second, healthcare workers shares burden of decision and responsibility through coordinated care. So we have dispersal of authority, empowerment through trainings, we have pathologists working with us, the clinical diagnostics, we have the radiologist, we have the pharmacists, community nurses who do the VDOTs, TB nurse, management team, and even caregivers. So the decision making is comparatively faster, and multiple people has the open communication line, not vertical. Providers must be trained staff to screen the patients, can do screening symptoms checklists, and in order to avoid missed doses of treatment, in Wagga Wagga we use evidence-based VDOTs, decentralized care, making sure relevant access to care at this point of contact. And yes, these healthcare workers are point of contacts between the patients and the management team. Moving on, local health district to adapt to new circumstances and learn how to address new institutional priorities by creating opportunities for knowledge creation and information flow that spearhead innovations. For example, medication supply, provide financial support for the patients requiring help with their travel cost. We have also the responsibilities of families and community responsibility, which is educating community about TB awareness, remove stigma. So it's the healthcare workers' job to educate the community, and that will remove stigma, and that will provide avenues to get access to service. Patients can be a good actors for infection control measures. Healthcare workers provide health education through infection control measures, and it will decrease the risk of transmission in the household and community. And finally, for the conclusion, to sum up the discussion, in our region, Murubiji, Riverina, Wagga Wagga, we have TB programs that provides optimal patient care with good TB infection control programs, early case detection, treatment management, and care. Here in New South Wales, we provided an effective strategies to end TB. This is with the use of evidence-based model of care called decentralization. It is important that there is a locally agreed strategy in model of care in place that reflects the epidemiology and demographic of the area and should have a clear line of responsibilities associated with appropriate participants. Yes, nurses are highly committed to addressing social change. Nurses are frontliners of TB care, a model of care developed through organizational challenges aiming for a better quality care outcome. Again, this is Noel Paradero, and thank you so much for listening to me. The next slide will be my reference list. And again, thank you and have a lovely day. Thank you.